I work with my team in University Hospital Split, intensive cardiology unit, and we will present one of our interesting cases. It's a successful use of VA-arterial ECMO in acute stent thrombosis and cardiogenic shock. It's a story about a 43-year-old man presented at the emergency department in our hospital after he was physically active. This patient had comorbidities, hyperlipidemia, arterial hypertension, and also history of cardiac arrhythmia from before. He was also visited cardiologist 3 years ago. We have no documentation about this. And his symptoms was intensive retrosternal pain, radiation to left arm, dyspnea, vomiting, nausea, and syncope. At admission at ECG, we recognized this patient have ST elevation in anteroseptal leads and ST depression in inferior leads. It was also recognition of atrial fibrillation and right bundle branch block. At physical examination, we have relatively low blood pressure, tachycardia, hypoxemia, severe shortness of breath, bilateral sway, sweating, weak pulse, and pale skin. In initial laboratory test, we have already elevation of troponin, and also lactate levels was 5.5. And he was also with lower levels of oxygen at the beginning. During the examination at the emergency department, he became unresponsive, and we just recognized that this patient suffered from cardiac arrest. We start with resuscitation, and we successfully defibrillated our patient. He was defibrillated because of ventricular fibrillation, and we already have a problem with respiration, and we put him on mechanical ventilation. After that, we transferred our patient to intensive coronary care unit. After that, we make a decision to make urgent cardiac catheterization in our laboratory and to make urgent coronarography to see what's going on. At coronarography, we recognize that we have total occlusion of proximal left anterior descending part of artery. I don't know it's working, but yeah. We put a stent in left coronary artery, drug-eluting stent. During intervention, we have a problem with ventricular tachycardia and ventricular fibrillation, and immediately we give our patient amiodarone. We put him on inotropic therapy on dobutamine and norepinephrine, and it's a question of hemodynamic instability immediately after intervention. We transfer our patient to coronary care unit. Our patients, our angiographic room is on first floor. We are on the 5th floor. He was also hemodynamic unstable, and we recognize that he has polymorphic ventricular tachycardia and ventricular fibrillation. We make several shocks and at beginning, and then we have in a moment stable rhythm, but after that we recognized repeated ventricular tachycardia and episode of ventricular fibrillation, and we make more than 40 defibrillation. We also give our patient further therapy, amiodarone, lidocaine, and also magnesium. He was further electrical unstable. We also put our patient on VA-arterial ECMO, and we just decide to repeat angiography, and we recognize that patient have acute in-stent thrombosis of proximal left anterior descending artery. we make a PC intervention and put a drug-eluting stent and also intervention with balloon. After intervention, we are satisfied with TIMI flow. We make also in coronary care unit echocardiography, and we recognize that we have anteroseptal akinesia, which reduced the ejection fraction. It was only 15%, and also a high degree of diastolic dysfunction. Further therapy in intensive cardiac care was levosimendan, and we give linezolid, meropenem, and colistin because we have infection. During further days, we have hemodynamic stability, and we don't need inotropic therapy anymore. We just decide to take off ECMO after 8 days, and we also make extubation. We also recognize that our patients have a local problem in a femoral region, and we make a CT scan and see that it's a problem with pseudoaneurysm of femoral artery, and we make consili and decide to make surgery treatment. We also, because of a lot of defibrillation and problems at the beginning, make CT scan of a brain, and it's no signs of intracranial bleeding. We also make echocardiography exam before discharge, and we recognize that it's a beta ejection fraction up to 40, but we recognize also that this patient have apical aneurysm. Laboratory test was quite well. We discharge our patient 55 days after beginning of hospitalization. He has no neurological deficits. He was cardiopulmonary compensated, hemodynamic stable without arrhythmia. We give also optimal medication treatment, bisoprolol, eplerenone, and ticagrelor, and atorvastatin, empagliflozin, and sacubitril valsartan. And after a short after hospitalization, we had follow-up, and he was even better on echocardiography, and it was no thromb in apical aneurysm. He was without chest oppression and without signs of heart failure, and we advised our patient that he take optimal medical therapy. It's a lot of medication, but he promised that he will take. And also we order him to very short follow-up, because we decide to just think about other treatment options too. Thank you very much.